Go for it.
All right. I'm going to get the participants pulled up here as well, and I'm going to start with introducing myself. I see a couple of familiar faces on there, so a shout out to Deborah, I see, and Lauren Nelson and Stephanie Hartman. I'm Chelsea Navarrete, and I'm going to be moderating the event tonight. I want to start right at 7 o'clock as we have a pretty packed agenda. I'm going to set the stage by talking through what to expect tonight. So I'm going to start with a couple of introductions here shortly of our panelists. And then I'm going to do some opening remarks, just brief opening remarks. Following that, Vemexi, who is a lawyer, is going to do about a 15 to 20-minute presentation on some high yield topics. We will then move forward to some panelist discussion. I'm going to feed them each a question to answer based on their own experience and expertise. And after that, we will move on to some of the pre-submitted questions from the group. The invitation says it goes until 8:30. That's for the Zoom in case we go a little bit over. If we're having lively discussion, we can certainly continue that. Otherwise, I'm hoping that we can get wrapped up around 8 o'clock so you can all enjoy your evening doing something hopefully other than work. Make sure you're muted if you're currently logged in. It should have been automatically set to that, but to avoid distractions, please double check. When we get to the point where we are asking questions, you can either unmute or raise your hand. Casey and I will both be monitoring the chat. If our panelists have the bandwidth to do so and answer some questions in there, that would be great as well. So I'm gonna go ahead and just welcome everyone. When I initially wrote this introduction, I thought it was mainly for Nebraska, and ends up there's lots of people who could be joining us from across the nation. But thanks to our valued attendees from Omaha to Chimney Rock, from coast to coast, for joining us today, and also to our distinguished guests who are volunteering their time and wisdom and have done a lot of tasks to prepare for this event tonight. On behalf of the Nebraska ACP, as well as the University of Nebraska Medical Center's Office on Belonging and Community Engagement within the Department of Internal Medicine, it's really my honor to moderate today's talk on immigration challenges in healthcare. So I will start with just a brief introduction of myself here. So if I can find my sheet of paper, which I, of course, immediately lost. So I work at the University of Nebraska Medical Center. I have a position as the Associate Vice Chair of Belonging and Community Engagement within our department. I also have a leadership position within the College of Medicine, doing a longitudinal clinical experience. I'm most recently the chair of Nebraska ACP's Health Equity Committee. My clinical and research interests include reducing health disparities, confronting barriers to medical training for students who are traditionally underrepresented in medicine as a first-generation college student myself, and also advocating for legislation and policies that impact patient care. I'm really looking forward to a candid and educational discussion tonight. Next, I'm going to have Vemexi go ahead and unmute and say her name and also where she is from, and then I will read her biography.
Thank you so much, Chelsea. Thanks for inviting me to come speak to you all. It is a pleasure to be able to do so. So my name is Vemexi Ruiz Chavez, and I am a senior attorney at CIRA, which is the Center for Immigrant and Refugee Advancement, and I am located here in the Omaha office.
Thank you. And you worked there since 2019, earned your law degree from the University of Missouri Kansas City School of Law. I have that your practice focuses on representing immigrants who are eligible for family-based and humanitarian-based immigration relief. As part of her role at CIRA, she manages CIRA's immigrant-focused medical legal partnerships, providing representation to clients referred through the immigrant-focused medical legal partnership, as well as providing education to their medical partners on various immigration-related issues. As the manager of the firm's medical legal partnerships, she is here today to share her insights. Next, I have Dr. Menning.
Yeah, so my name's Melanie Menning. So I am a family practice doctor at UNMC within the Department of Family Medicine, and then I have the pleasure of getting most of my clinical time actually down at OneWorld Community Health Center, which is a federally qualified health center here within Omaha that serves a very large immigrant population.
Mhm. And we learned that she is a Nebraska Wesleyan alum, majored in biology and Spanish, completed medical school and family residency training at the University of Nebraska Medical Center, where she also completed the Community Health Center track. This was followed by achieving her Master's of Public Health and Community-Oriented Primary Care from the University of Nebraska Medical Center, and she currently serves as the Associate Program Director of the UNMC Family Medicine Community Health Center track, and has a couple of other leadership positions, including the Assistant Medical Director at OneWorld Community Health Center. She's been caring for immigrants and refugees at OneWorld for over 10 years and remains involved in medical education by overseeing the New American EMET for medical student that teaches immigrant, asylee, and refugee health. Her research includes projects to increase Spanish-speaking primary care providers through a longitudinal Spanish program for residents and fellows, and to improve health disparities for new Americans, such as diabetes and cervical cancer screening. Next, I will turn to Dr. Kovar.
Hi, I'm Nora Kovar. My clinical practice is in geriatrics here at the University of Nebraska. And then I also work with the internal medicine residency program on the newly developed health disparities track.
Mhm. And I've had the privilege and pleasure of working with Dr. Kovar during some of her training. She did her medical school residency and geriatrics fellowships at the University of Nebraska Medical Center. And this sounds really prestigious, though I've never heard of it. It's the current recipient of the HRS-AK Award through the Geriatrics Academic Career Award Program. And her work there focuses on geriatrics education and care of the underserved adults. She collaborates with Dr. Menning on the New American Special Interest Tract for medical students and continues to be involved with the internal medicine residency, specifically around community health and care of medically and socially complex patients. She's a bilingual provider in English and Spanish. And her clinical work includes primary care and geriatrics, and I'm hoping that she will share some of her unique experiences in regards to immigration in the geriatric population. Next, we have Augustine.
Hey guys, so my name is Agustin Delgado Jimenez. I am from UNMC, Specialty Care Center, and so we deal with, HIV and AIDS. That's our focus at that clinic.
Yeah, so he works at the UNMC Specialty Care Center, as you mentioned. This clinic provides high quality, low cost healthcare services to those in need in Nebraska and the southwest Iowa area, serving over 1,300 patients. He has a very solid connection to the Latino community and serves as an educational tool where he hopes to close the gap between community barriers, stigma, and engagement in medical care. HIV rates are increasing within Latino communities, and he seeks to learn why most of our Latino communities don't get linked into care, including barriers such as immigration status, insurance, and language barriers. He hopes to close that gap, and we support him in that, as well as helping patients navigate legal representation and resources while getting the essential medical care that they need. So a thank you and a welcome to all of our panelists. I'm going to start with just some open remarks here to kind of set the stage. I think many joining the call, if not all, are physicians. and we can both respect and appreciate the critical intersection of public policy and human experience. We know the realities of immigration meet the challenges of healthcare delivery, and we want to do so in a manner that does no harm. So this discussion is timely for both our state and our nation. Specifically in Nebraska, we are home to over 145,000 immigrants, which makes about 8% of our state's population. These are our friends, neighbors, co-workers, and classmates. They are vital to our state's economy and comprise nearly 20% of our workforce. They also contribute to our healthcare system. It's estimated that 17% of healthcare support workers in the state of Nebraska are foreign-born. Immigrants face significant challenges in healthcare due to language access, legal status, and cultural barriers. It's estimated that 22% of non-citizens in Nebraska are uninsured. That is nearly 3 times the rate of native-born citizens. This can lead to delays in treatment and worse health outcomes. On January 20th of 2025, our 47th president was sworn into office. I think that we can all agree that it has been a fascinating and at times confusing course in regards to immigration. The rhetoric and the policies have left many unsettled because of their ambiguity. Some messaging emphasizes strong borders, law and order, or even merit-based systems, but this coincides with the measures we see like family separations and travel bans. There's inconsistent enforcement and shifting interpretation of these policies, and it's left many federal agencies, legal experts, and immigrants uncertain about what rules exist, what will be enforced, and what the overall goal is. And where does that leave us as physicians as we care for our patients? What is our role? What is our duty? How do we do no harm, the oath that we promise to do? So let's take a moment to take a pulse on current legislative actions across the nation. In California, Governor Gavin Newsom proposed freezing enrollment in Medi-Cal for undocumented adults starting in 2026, and then imposing a $100 monthly premium for enrollees that cannot provide satisfactory immigration status starting in 2027. A closer neighbor in Minnesota, they're looking at state-funded healthcare to undocumented residents. It's become a point of contention in state budget negotiations. And then at the federal level, there has been policies proposed, such as the Protect Medicaid Act. This legislative proposal aims to prevent states from using federal funds to provide Medicaid benefits to undocumented immigrants, stating that doing so places undue financial burden on American citizens. So this climate of uncertainty may deter immigrants from seeking necessary medical care due to fear of deportation or legal repercussions. So today's program is designed to illuminate these realities and explore actionable solutions. I know our expert panel will share insights on policy development, community health strategies, and frontline experiences. As physicians, we must learn, listen, and lend our voice to these vital conversations to ensure that all of our patients have access to healthcare, and that we are doing so in a manner that aligns with our code of ethics as well as the laws of our great country. So with that, I'm going to turn it over to Dr. Menning to share a patient story.
Apologies, this worked when we trialed it, but now it disappeared. Give me 1 second. There we go. Okay. So I think before we talk about some pretty heavy topics, it's nice to ground ourselves with a patient case and put this back into perspective and humanize what we're going to be talking about tonight. So I want to tell you about a 17-year-old female that I've had the pleasure of taking care of for quite a while now. She first presented to our clinic actually after arriving in the US about 8 days prior when she was 13. Prior to that, she had been raised by her sister in Mexico as mom and older brother had already came to the US for work. We then lost her to follow up for 4 years, and at 17, she now presented for an immigration physical as she was going to be a recipient for DACA. At that visit, she was noted to have a high blood pressure, which led the clinician down a pathway, including ordering a BMP, which revealed that she was basically an end-stage renal disease, and her kidneys were only functioning at about 10%. And so that set off a chain reaction of lots of different things. So we had no insurance, no green card, and working on DACA. So this was also back in 2020 when DACA still was able to be enrolled in. So looking at the healthcare immigration intersection, some questions that this case raises. So who needs an immigration exam? What other immigration forms may a physician be asked to complete? What additional screenings might be needed? And how can my role as a physician impact someone's status, asylum case, deportation, things like that? Another question that came up is what insurances do DACA recipients qualify for, if any? And is there a difference before and after age 19? For those not in Nebraska, 19 is our age of consent here in Nebraska. How does immigration status affect transplant? If you are not aware, if you lack documentation, you usually cannot get a transplant because you need to have continual insurance status and ways of accessing social supports that a lot of our individuals who do not have a status don't qualify for. How does immigration affect social supports and what resources she can receive? And does she qualify for a different immigration status that could possibly open up more benefits? And us as physicians are not good at answering that question, so who can help me figure that out? And so with that, I want to kind of set the stage for our discussion, and hopefully several of these questions will be answered throughout our time tonight.
All right, thank you, Dr. Menning. And now we're going to turn it over to Vemexi to share her screen.
Thank you. Okay, give me a second here. Can you all see that? Okay, perfect. And you can just see the slides on my notes, right? Okay, perfect. Always making sure. So my name is Vemexi, as I was previously introduced. And today I have a few slides that I prepared. Basically, I'm just going to be talking about some questions that I know all of you have as it relates to non-citizen patients that you all serve, as well as just how that relates to your all's practice and immigration law in general. And so that's what the presentation I will be presenting on today is about. Before we start, I wanted to first give a little bit of an overview of my role at CIRA because I think it will help inform the perspective that I'm coming from, as well as how I'm privy to the information that I have now. So a brief overview of immigrant-focused medical legal partnerships. So as was mentioned earlier, I'm the manager of our immigrant-focused medical legal partnerships at the firm where I work at, which is called CIRA. And basically, what immigrant-focused medical legal partnerships are is that traditionally, medical legal partnerships are between medical providers and legal providers where they're trying to address social causes of health, right? And so the legal providers are typically organizations such as Legal Aid that are receiving federal funding that have restrictions on the types of patients that they can serve. And specifically, there's federal funding restrictions on legal aid being able to serve undocumented patients and immigrant patients in general. And so there's this gap of non-citizen patients that do not have their legal services needs met, and specifically, they don't have their immigration legal services need met. And so that is where we have unrestricted medical legal partnerships, which is otherwise known as immigrant-focused medical legal partnerships. And this is basically, we have two IMLPs right now. We have one with Nebraska Medicine and another one with Children's Hospital. And what this looks like practically is us at the firm, we receive referrals for your all's patients to be able to represent them in an immigration case. Depending on the circumstances, we'll represent them in their immigration case. And so there's a lot of benefits to having IMLPs. Really, as was mentioned earlier, immigration status is really important for health insurance eligibility. And so one of the main benefits that IMLPs bring to the table is that if the non-citizen patient is being represented by immigration counsel, then the Immigration Legal Counsel can assess whether the immigration benefit they're pursuing may open up access to health insurance benefits. And specifically at our organization, what we've looked at is the different types of immigration status that may lead to Medicaid. Our understanding is that Medicaid is a really beneficial form of health insurance because it can facilitate discharge. And as Dr. Manning mentioned, it also can facilitate different transplants. And so that's kind of what we've been focusing on at our organization is how our representation can lead to opening up the door for Medicaid for these patients that you all are serving. And so with that, that leads us to our first question, which I already answered, but there's much more to say about this. So question number one that was submitted is, can immigration status affect a patient's eligibility for Medicaid? So the short answer is yes, as I just mentioned. While there's no immigration status requirement for emergency Medicaid, for a non-citizen patient to qualify for full scope Medicaid, these patients must have an immigration status that qualifies them for such. And I apologize, when I am referring to non-citizens, I'm referring to individuals who are not yet U.S. citizens. So this may include immigrants who have a legal immigration status in the United States. It can also include undocumented immigrants who do not have a legal immigration status in the United States. So when I use that term, that's how I'm using it. And so to get a little bit into the law, the Medicaid law, as it relates to non-citizen patients, as you all know, Medicaid is a federal state program. So there's federal laws as well as state laws that govern Medicaid eligibility. And as it relates to non-citizens, there's several federal laws that change and add Medicaid eligibility requirements for non-citizens. But I would say kind of like the foundation and the baseline of the federal law comes from a federal law called the Personal Responsibility and Work Opportunity Reconciliation Act of 1996. And basically, this law is kind of like, it's the framework for a lot of Medicaid eligibility for non-citizens. And so according to this act, states can either follow their federal mandates, follow that statute that I just mentioned, or they can make access to Medicaid more restrictive for non-citizens. And so for purposes of today, because this is a short time and this is a very big topic, I'm just going to talk about the Nebraska laws because it is the most restrictive, laws for non-citizens, right? And so we'll kind of just touch on that today. And so the Nebraska legislature at the Nebraska Administrative Code Section 2, it's that second bullet point right there. Section 2 outlines eligibility requirements, or specifically the U.S. citizenship and alien status eligibility requirement, right? So as you all know, and I'm sure you all know a lot more about Medicaid eligibility in general, but one of the eligibility requirements is immigration status. And so this is the section of the title of the Nebraska Administrative Code that kind of governs that, which immigration categories or immigrant categories qualify for Medicaid. And so the basic framework from this Nebraska Administrative Code is that there's generally two categories of non-citizens that qualify for Medicaid. And so this is a legal term. So number one, that third bullet point there, that first category is qualified aliens. So that's a quote. That's just how they define it. That's how they word it. That's how they phrase it. And then the second group of immigrants that qualify under this law is lawfully present children and pregnant women. And so there's a lot to be said there. And as I mentioned earlier, the federal laws change a lot depending on what's going on in immigration. So a lot of federal laws have also expanded Medicaid eligibility for certain Afghans who entered the United States when there was the evacuation from Afghanistan. So there's a lot, but this is from this Nebraska Administrative Code. So to go ahead and give you some examples on who a qualified alien might be. So number one, we have LPRs. It's that fourth bullet point right there, LPR. That is just the short version of lawful permanent resident. So these are people who have green cards, meaning they are living in the United States with the permission to live here indefinitely. They do not have to become U.S. citizens, but depending on their situation, they may be eligible to become U.S. citizens. But they don't have to. They can remain in this type of immigration status indefinitely and be able to live in the United States indefinitely. So this is an immigration status that is considered to be a qualified alien in Nebraska. And so they would be eligible. This is a Medicaid eligible immigration status. Another common immigration status that can qualify for Medicaid are refugees and asylees, which I'm sure, as I've heard the bios from you all, at least the panelists work with refugees, asylees a lot, it sounds like. So, but just for everyone, so we're on the same page, a refugee and asylee, these are people who have a well-founded fear of future persecution in their home country because of their race, religion, nationality, political opinion, or membership in a particular social group. And so the difference between a refugee and asylee is a refugee applies for this kind of status outside of the United States, and then they're processed and they enter into the United States as a refugee. And this is an immigration status that qualifies them for Medicaid, right? Or it's a Medicaid eligible immigration status. Asylees also have to meet that definition, but they're applying for asylum within the United States. But they have to meet that same definition of being a refugee. So that's kind of the difference there. Both of those statuses are Medicaid eligible immigration statuses. Another one that you may commonly see are Cuban Haitian entrants. Again, this is a legal term. It's pretty specific. I'm not going to get into the weeds, but basically certain Cubans and Haitians, depending on their circumstances, may be eligible for Medicaid as well. It's not all of them, but many of them are, just depending on their case. And then some examples of lawfully present individuals include temporary protected status, asylum applicants, deferred action. This does not include DACA. And then also something called special migrant juvenile status that is available for minors. I'm not going to get into those statuses, the lawfully present statuses, just because I think we'll run out of time. But those are just some examples. Important to note that some immigrants have to wait out a 5-year bar before they can receive Medicaid, and some are exempt from this bar. So there's kind of another barrier. Even if the immigrant has a Medicaid eligible immigration status, they may have to wait 5 years before they can apply for Medicaid. And again, that's going to depend on, it's going to be very fact specific because there's also other ways that they can meet that 5 years without actually having to wait the 5 years. It depends on how many qualifying quarters of work they have. So just important to note that it can be a complex analysis. And so it's really best for legal counsel to get involved just to help determine whether their immigration status may qualify them for Medicaid. And also, I just want to note that I know I'm highlighting here that there is eligibility for immigrants for Medicaid. There is Medicaid eligibility for immigrants, but the baseline rule is that it's pretty restrictive for non-citizens. And so in general, even if the non-citizen patient has immigration counsel, it doesn't necessarily mean that that their immigration status will open up a way for Medicaid. That is the goal, that is the hope. But it is quite restrictive. But it is possible, depending on the circumstances. Okay, so moving on to the second question. Where is it? Question number 2, it says, where can I refer immigrants who need immigration legal aid? So if you and your patient are at UNMC, as I mentioned earlier, our organization, CIRA, has a partnership with you all where we receive direct referrals from you all on an expedited basis. And so you can refer them directly to us by emailing our referral form to those 2 emails. I'm not sure if you all have access to that, but I am happy to, maybe I could drop it in the chat after okay, I'll do that. I can drop it in the chat once we're kind of in the open discussion section. And yeah, so you can do that, and it's on an expedited basis, meaning that the patient will hopefully get a consultation with one of the attorneys at our organization in the next month. It's possible that that patient may be screened out by our intake specialist as not having immigration relief, but and that's just our intake team that they do an initial assessment to decide whether if there's even any immigration relief that appears available. If they're screened out, then they won't have a consultation with us. But if they're screened in, they should be placed with one of the attorneys here within the next month. If you and your patient are not at UNMC, we do, and you're residing in Nebraska, if the patient is residing in Nebraska, the patient may call our hotline, and that's our number right there for a legal screening. If they're screened in as having potential immigration relief, they will be placed on a wait list. So it does take a little bit of time if they call a hotline. But I still highly encourage it just because we do see those patients. It just takes longer than if they weren't referred through a medical partner. So that is how they can receive immigration legal aid. I'll make sure to drop the referral form in the chat. Okay, so question number 3, are there clinics or resources that provide care to uninsured immigrants? In general, I would say that if you all work with medical social workers, they're probably the best point of contact with this. We do have a social work department in our organization, and so I usually reach out to them. And our lead, the director of our social work department gave me this information. But of course, if you know of any other clinics, obviously those would be recommended as well. So in Omaha, there's the Heart Ministry Center, specifically the Monin Clinic. In Lincoln, there is Clinic with a Heart and People City Mission. In Grand Island, there's Heartland Health Center and Third City Community Clinic. In Scottsbluff, there's Community Action Health Center. But yes, like I said, if you all work with medical social workers, they probably would be the best point of contact for your particular patient. And I am more than happy to share I've already shared my slides earlier to Casey, I believe, but I can also drop that in the chat as well if you want to just have this as a reference. So question number 4 is an important question. It's how can I help patients who express fear of deportation while staying within my practice scope? So the source of this is there's a body of research called sanctuary doctoring. And this comes, I'm not sure if you all have heard of this, but this comes from Dr. Mark Koszewski and at Loyola University in Chicago. And this concept of sanctuary doctoring is really born from the idea that as medical providers, you all desire for the community, for communities in general to be healthy, right? And non-citizen patients are a part of the community. If they are not seeking healthcare because they're afraid of immigration enforcement, in other words, they're afraid of being deported if they are out in public, such as going to a healthcare setting, not only will their health decline, but also the health of the community may decline in the sense that communicable diseases can spread. There can be more distrust within the community, creating more situations where there's going to be lack of trust in law enforcement in general, not reporting crimes. So it just leads to more unhealthy environments. And so this is this body of research is called sanctuary doctoring, and this is where we get a lot of our best practices that we try to promote from. And so some of the best practices include creating a welcoming environment for dialogue. And so I understand that as medical providers and also as medical social workers, a lot of times when you all are working with patients, it's necessary to ask for the immigration status, for example, to fill out a Medicaid application, right? But if that's not the case, it's best to not affirmatively ask the question because it may just put them a little bit on edge if it's not necessary, right? It's really best to create a welcoming environment for the patient to initiate, to give them the choice to initiate. One way that we have seen that this can work is just having resources available in in the healthcare settings, right? Like maybe in the lobby area, just having, even if you just like cards that say are like that have our organization's information or something, or pins, like pins that you can put on your or buttons that you can put on your shirt or something that say like immigration worries, come talk to me. It can say it in Spanish, or it can say it in whatever language of the patients that you most see. And then it kind of just signals to them that you are a safe person to talk to about immigration, not for obviously immigration legal advice, but just if they have concerns, they can just talk to you for resources. So that's kind of one way to signal to them is finding ways in the environment to put signals that you have resources, right? Second bullet point here is normalizing the immigration conversation. And this is really just providing empathy to the patient. So if they do mention something that they're very stressed out, just saying like that's understandable. There's a lot of people in your situation right now, and it's understandable why you would be stressed out about this. Yeah, and just telling them that you care about this because you care about their health, and you know that this can affect their stress levels and can affect their health. And that's just to create empathy. And then the third point, which is probably the most important point, is to try your best to point them towards resources. So obviously, it's understandable that you do not have all of the answers to all of their immigration questions. And so really the best thing to do is to point them towards resources where they can find immigration legal services. So we have a website that has plenty of information on Know Your Rights, on what the patient's rights are when they're immigrants and they're in the healthcare setting. You can print that and have them in your clinics. You can print as many copies as you want and have them in your clinics, and then your patients can take them. You can just refer them to that website. The next slide is going to have that website for you all. And then also we do have a private attorney referral list. So if your patient wants to see, for whatever reason, if they want to see a private immigration attorney, we can give you that list as well. I can also drop that in the chat if you want. So they can seek a consultation with a private immigration attorney. And so those are really, I think the best things would be to point them towards those resources to get the immigration legal services needs met, to get those needs met. And yeah, those are some of our resources, and I will put this in the chat.
Perfect. Thank you. That was very informative. I'm really curious, and I don't think this is a high yield topic, but why the 5-year ban exists for some and not for others, and the process by which that is decided. But I think that's probably too detailed. I would also love to know if anyone knows how we can get those buttons for, immigration issues. Feel free to talk to me just to kind of disseminate that amongst our department and give the people the option to wear it on their white coats when they're seeing patients. So I would also like to take a moment because I saw Lauren Nelson is on, and she is our current governor. And so I really appreciate her support and being with us tonight. Lauren, do you want to say hi?
Wait, oh, yeah, thanks. I am really excited to be here to learn. And I'm glad to see everybody's here, and I would love to hear more about the buttons. So, thanks y'all for joining and for our presenters and Chelsea for hosting.
Yeah, thank you, Lauren. All right, so I'm going to give each of our panelists like a pre-planned question based on their expertise. And I'm going to start with Dr. Menning here. What kind of barriers do immigrants most commonly face when seeking healthcare?
I think a couple of these already came up, but one of the big ones is language access, and it's not just getting getting a translator in your visit, but even how do I even call and get an appointment? Does anyone speak my language? Things like that. Insurance is another big thing, or how am I going to pay for this? We've talked about some of the barriers to getting insurance and access to different financial assistance. One good thing to know is financial assistance at Nebraska or at CHI don't require immigration status, and so patients may qualify for those type of things. Especially in the current environment, immigration and fear is a big one. Am I going to be safe? What type of information is a provider recording? Is basically providing any of my information trackable, or could this be used to locate me by immigration officials? Discrimination is also a big one. Unfortunately, our patients from Latin America and others countries do face a lot of discrimination just by their status of being immigrants. And then also differences in healthcare. So outside of the US, it's pretty common that when I need healthcare, I just show up for a visit and I'm seen in the order that I show up. Whereas that's very different here in the US. So knowing I need to find a provider, I may need a referral to see a specialist. All of those things are very, very different. And so some of those system navigation things can be really difficult for patients.
Perfect. Thank you. Dr. Kovar, I have you up next. So, what are the most significant benefits to both immigrant health and society of ensuring that undocumented immigrants are able to access healthcare?
Sure. So I'm gonna assume for the sake of time that we are addressing this from a purely utilitarian perspective. And so, not from the angle of, is it worthwhile to take care of the person in front of you and, respect their dignity just from that standpoint. And so Vemexi started alluding a little bit earlier. Unsurprisingly, when people have access to healthcare, communities are healthier. And where that benefit really kind of begins to become evident is where we start to talk about workforce. And so there are 8.3 million undocumented immigrants in the national workforce. That's a little under 5% of the total workforce. And they actually have a labor force participation rate that is higher than the native-born population. Most of them have lived in the United States for 16 years or more. And if they have been working during those 16 years, they have also been paying taxes. And so even if people are not citizens, they are still contributing to the pool that provides for the benefits that citizens are receiving. When we start to look at the healthcare workforce specifically, is a little bit where my world comes into play. So I practice in geriatrics, which is a field where I have a lot of patients who are relying on other people to take care of them, whether that's their family members, which is more the case in a lot of the immigrant communities, especially, or relying on kind of long-term care services and supports, whether that be at home or in an institutional setting. And when we look at those kind of caregiving settings, not necessarily undocumented specifically, but a lot of immigrant cultures have really strong caregiving cultures. And these communities represent a lot of that workforce that a lot of our patients depend on as they're aging. And so immigrants fill about 15% of nursing positions in the United States, about 28% of healthcare aides, about a third of the home-based care workforce is foreign-born, and about 20% of childcare positions. So if you are in a position where you are taking care of someone else and need support to do it, these are issues that you should care about. I'm a mom who, like a lot of physician moms, has had issues with daycare staffing over the last few years. And so, that's an issue that comes into immigration. If you have parents who are aging and you are anticipated being involved in finding them care as they age, this is important. I have patients kind of on the other end of the spectrum who have all the money in the world and want to remain at home, and can't figure out how to do it because they can't find workers who are able to be there for the amount of time that they need. And I think it's important to remember that none of these cases occur in isolation. So the majority of households that have an undocumented immigrant in them are of mixed status. And so family members' health and, the kind of fear or anxiety that can come with access to care really plays off of each other. So I have older adults who are here and have aged and had family members come to join them. I have older adults who have come here to join family. And if there's a mismatch in immigration status, that can really affect care for everybody involved or everybody involved's ability to work. And I have plenty of stories too. I have people who came here to visit family and had a medical event happen just because they're older and medical events happen, and had planned to be here for a certain amount of time, and then something happened, and now we're in the position where our visa is going to last this long, but this problem's going to take this amount of time to fix. And so it gets a lot more complicated than just saying, somebody decided to be here under this status or this status. And so, kind of summary wise, these are important members of our community, regardless of what their exact status is. And each case involves a lot more people than just the one individual patient.
I think that's a fascinating take on the community. And I, as a hospitalist, have seen this exact situation where someone is visiting a family member and becomes very ill and has to be hospitalized. And that can be really, really challenging to navigate the system, way beyond my area of expertise. But these things happen, these are a part of our clinical practice. And I also think it's an interesting point that many immigrants are actually paying into the system. I think there's a lot of conversation around that, especially when it comes to receiving Medicaid benefits, like, is it being paid in? And it sounds like in a majority of cases, it probably is. You can correct me if I'm wrong, Nora. But yeah, fascinating. I'm going to move on to Augustine, and I think I'm going to ask you two questions. The first one, I'm glad you agreed to take this because I think it's a really important question and I don't know the answer to it. So, what should I do if the police or ICE show up at my clinic?
So, let's see, where do I even start? So I guess, bottom line, it's trying to educate your staff in clinic, of myself, and my role with, the specialty care center. I'm a community health worker slash medical case manager. So I'm firsthand, encounter when it comes to individuals who are newly diagnosed with HIV. So trying to so that puts me in the front end of things, me, myself, I went through the loop of, immigration, and my process took about 20 years. So pretty much I heard it all, seen it all, been there, done that kind of scenario. Again, bottom line, it comes down to educating yourself. What's out there. I know that the media throws a lot of fake news, but if you follow the right um, groups on social media, or stay on top of, the news and whatnot. And then we have individuals like, CIRA here in Omaha. And we also have the International Council for Refugees, who provide all these resources for community health workers slash, medical case managers. And so again, putting together a group that, within the space that you are at, and educate them of what's, presented, present, and then, move forward with, your first contact, which is, the front desk individuals. Let them know exactly what it's protocol based on your location, your space. We all work differently, and so I've heard clinics where they have, a VIP, where that means all individuals who have non-legal status can, be room into, right away get room into a room, just because, they show that fear. So our ultimate goal here at, the Specialty Care Center is, not to lose those individuals out of care, just because, they're afraid of what happens if I shows up at, the location that I've been seen at. Just, that fear, that they live on that constant fear of, what if? And so we can make that, VIP, get them room as soon as they get, to your location. And so at least they feel safe that way. I'm not saying that, it's a guarantee that it's not going to go in, but then again, there are laws that they have to abide by, and, for them to take action. I know that I learned that if in the waiting area alone, it's an open public space. So any officer, agent can, come into your space. And because it's a public space, they're allowed to proceed with the proceeding that they have to do. But if they're within the room, then there's that door that they have to go through. But then again, if you educate the front individuals or have a certain individual that needs to take action, if something like this were to happen, then, that's valuable within, the clinic. That's my take on that. And that's what I've learned throughout this process. And again, it's never a guarantee, but if we can make the life easier for those individuals one way or another and keep them engaged in care, which I think it's the number one priority for everybody, especially, in the HIV world. I think it's a must. And that's my take on that, and that's what I've learned.
I think that is an invaluable tip that I hadn't thought about before. I know in our clinic we have a waiting room and then we have locked doors going back to our clinic rooms. And so if we can expedite the rooming of patients to not be in the sitting room, it sounds like that might make them more comfortable. I'm curious, if ICE shows up, do we have to let them in to the clinic? And what are we allowed to say or not say? And anyone can jump in on this issue.
Depends on the stance your healthcare system has taken and how they label rooms. For example, OneWorld, our waiting rooms are private. That requires a warrant to get into.
Okay, so at OneWorld, they have to present a warrant before they could enter into the patient's personal room,
The waiting room for our
even the
clinic
waiting room.
are private spaces.
Okay. Okay. So without a warrant, they do not have to be granted access. Okay. I'm curious, Nora, do you know what ours is? Or Augustine, you also work for the University of Nebraska, or
UNMC is not that way.
is not that way.
UNMC, it's public space, so it does not need a warrant.
Okay. Even within the individual clinic rooms,
Clinic rooms would be private space, but
private
waiting room
space.
is not. Waiting room and hallways.
Okay. Okay, I had no idea. So, if a patient is in a room and not in the waiting room, and the police are asking to see the patient, what can you say?
I guess it
Oh,
comes down to having a warrant. I think that's the number one key to have, and make sure that it's an actual warrant. Because there's, multiple warrants out there, that individuals bring up and whatnot, but just make sure that it is a legal document. Um, that's my take. I don't know if, is it Vemexi has
Yeah,
anything to
I'd
add?
love for you to weigh in as well, Vemexi.
yes, sorry, I was putting the resources in the chat. I want to make sure you all had that. Can you repeat the question one more time?
Yeah, so if, say, a patient has been removed from a public space, like at the university, and now they are in a private room, and ICE is asking to see them, and like, what are your options? Like,
Okay,
if they have a warrant, it sounds like you do have to let them in. You
right.
you just tell us what would be appropriate.
Right. So if it, just like Dr. Menning said, those, I don't know what you're calling, like the patient rooms, like where you're actually treating the patient, they are private spaces, which means there is a reasonable expectation of privacy. So ICE can't just come in and open the door and, try to arrest the patient. Um, they can enter in with a warrant or if somebody gives them permission to enter in. And so if they have a warrant, then it's really best to have a protocol to for the provider or for whoever is with the, yeah, I guess it would be the medical provider who's with the patient to have a protocol for them to reach out to legal counsel to review the warrant if ICE has a warrant, to review the warrant to make sure that it's legally sufficient. Um, and it really should be your legal counsel that makes that determination as to whether it's a valid warrant for ICE to come in and make the arrest. Make the arrest or yeah.
If the patient is roomed and they ask if the patient is there, do we have to confirm that they are there?
Yeah, that's a good question. Yeah, I would say no, because you have a right to remain silent. And so really the best thing would be to just tell the officer, like, we have a protocol where we will only allow with a valid warrant. Unless you have a warrant, we're not going to let you in. And then if they give the warrant, then say, okay, our legal counsel has to review this. I can't go any further.
I think a good general guideline to think about is in the absence of a specific warrant with, the specific parameters of that warrant listed out, HIPAA applies the same way as it would for any other patient in that setting of care. And so if you wouldn't, give an individual patient's name at the front desk or at the desk in the hallway on the inpatient service, outside of, for kind of any reason, then you don't have to do it for a law enforcement official in the absence of a warrant, is my understanding.
Perfect. I am unaware if in the state of Nebraska this has actually happened at any clinics, if anyone could, not that we're aware of, but I think we all just want to be prepared to advocate for our patients and do the right thing. Now, Casey, we're getting a little bit low on time, but if you could put the PowerPoint back up, we'll go through a couple of those discussion questions. First, I will say there were a lot of visa questions that were pre-submitted. We are not qualified to offer advice in that regard. So what I did is I put the information for contacting the Graduate Medical Education Office for both UNMC and Creighton, so you can reach out to them and ask for guidance on that specific issue. Next slide. Okay, I'm going to actually go to the next question in the interest of time. Okay, one more question. I have 6 here, so I like this question because it came up twice with 2 different angles. How can U.S.-born physicians and medical students be effective allies to immigrant colleagues? And what can we do to reassure our community partners and organizations within the Hispanic community that they can continue to collaborate with health systems to address social determinants of health? And that is open to anyone on the panel.
So,
Oh,
go ahead, Dr. Kovar.
okay. I think recognizing that, should situations that can feel hard to navigate arise, immigrant colleagues might be in a more uncomfortable position in terms of being able to take the lead. So being willing to step up and be the patient advocate, in that particular case can be really helpful, a helpful way to support colleagues.
On the community partner front, I think it's re-emphasizing our values. So as physicians, we took an oath to take care of our patients and to do no harm. And staying true to that is really important. Regardless of someone's documentation status, they need health care, and that is your job. And their documentation status shouldn't impact your desire and or ability to care for them. Now, yes, there may be some extra hurdles and other things that have to be taken into consideration. But the idea that we are still here, we are still caring for patients, we are going to do things within our power to, within the law, protect your status and protect you as a patient, and making sure the community is aware of that. Also being aware of who are your friendly community resources. So there are a lot of resources in town that require Social Security. I don't send a patient there. That is a great way to break trust of sending them somewhere that's going to right up front ask for a Social Security number. And so being aware of what those resources are, how to access them, how to keep your patient safe outside of your walls as best as you can. And then knowing your resources like CIRA in town of how patients can get help.
Great. With the participants here, I was just going to see if there were any questions in the chat. It looks like it's mostly information. So what I will do is I'm going to ask one more question and then I will move to our conclusions. Let's see here. Okay, this is a legislative advocacy question, and I think it's a good one. What do you recommend we do as physicians as far as advocating for migrants at the border and other immigrants and migrants already here or trying to come to the United States?
First thing I would say is reinstate immigration enforcement has no role in healthcare and should not be welcome in healthcare spaces.
I like that. Sweet and to the point. Anything else to add from the group? Okay. Lauren, perhaps do you have any thoughts on advocating, especially through Nebraska ACP on this issue?
I am, as far as advocacy, I would actually turf that question to Dr. Hartman because she is our advocacy guru for Nebraska. Um, but I think if this is something that people are interested in, Stephanie is our go-to from an advocacy standpoint, but from other activities, involvement, reach out to us in ACP Nebraska, and I'm sure y'all's resources through Nebraska Medicine. Um, I think community building, however we do it, is vital. So we've got a great group of interested people willing to be helpful and be advocates on this Zoom call. Um, and I think that's a great place to start. So we've got great community and resources, and happy to have ACP be a help there. And Dr. Hartman, if you've got any advocacy specific issues, um, I'm going to dump it at you.
Thanks. I do have, I guess, a couple of thoughts on this particular topic. I think I'll just echo what Dr. Kovar said about acknowledging that people are deserving of care just because. And I think elevating that in the advocacy space to whoever is making policy is paramount. Um, and just as Dr. Menning said, that this doesn't have a place in healthcare. And then I guess, other point about that is if from an ACP standpoint, there are a lot of policy statements around how this could be done better. And so using your voice to make sure that those changes either stick, at a federal level or they stick at a state level. There are playbooks written for that, and I would love to work with that with anyone on that. And then I think for me personally, and so if anyone is interested in potentially crossing from that advocate to more of an activist space, this is yeah, a place where I think there is some use towards, mutual aid and collective action that maybe doesn't stick necessarily in a policy sort of way, but I do think that there are a lot of physicians who, feel it on their heart to spend time in that way in the community, and so I think all of those things are valid to pursue.
Yeah, and Stephanie, perhaps you could put your email in the chat for anyone who may want to be included in some of your advocacy work. I think that would be great. And thanks again to everyone who contributed tonight. The panel listed a lot of behind the scenes work. And so I just want to say a deeply grateful thank you to each of you for being here tonight. And I'm hopeful that this will also disseminate some through YouTube, because I think it was a really fruitful and motivating conversation. This was co-sponsored through Nebraska ACP, Health Equity Committee, as well as the UNMC Department of Internal Medicine, Office of Belonging and Community Engagement. And as we end, I was trying to find a way to end on like an inspirational note because I know that these things can be really heavy and really hard, especially over the last few months. So what I did is I looked up the modern Hippocratic Oath and I thought I would read a few lines for that from that. I will remember that there's art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. I will remember that I do not treat a fever chart, a cancer's growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to care adequately for the sick. I will remember that I remain a member of society with special obligations to all my fellow human beings, those sound of mind and body, as well as the infirm. May I always act so as to preserve the finest traditions of my calling, and may I long experience the joy of healing those who seek my help. So with that, I will say thank you to everyone for joining. And if you have any follow-up questions or ideas or comments, reach out to Casey or myself. This was our first time ever putting on a webinar like this, so I'm always open to feedback. Otherwise, I hope everyone has a great night with their family, and thanks for joining. All right.